I think we're going to start so we can stay on time. I'm Julie, this is Andrew. We're co-chairs for this talk tonight. So if you guys have any complaints, our names aren't really that. So, I just want to give you an idea about what's going to go on here is that we're talking about musculoskeletal issues, and we realize that there's people out there that have lots of experience. So we're hoping that this is a refresher. But now with everything growing and some new people here, we just want to kind of give you a taste of some of the things going on to make you really think about what's going on in your clinic and with your patients so that you can maybe address them. And if there's things that really excite you, then maybe you need to take a deeper class on some of these things too. So.
All right. So again, like Julie just talked about, we'll explore musculoskeletal issues, including the shoulder, thoracic rib, pelvic floor, and then age-related sarcopenia. In this session, we'll review anatomy, discuss evaluation, interventions, including some manual therapy techniques, exercise, and education. Just a few objectives that we have. You guys can read those.
And Andrew and I have nothing to disclose.
Nothing to disclose, yes. So the first speaker today is going to be John.
Well, good afternoon, everybody. Thanks for being here on the first day, end of the first day. So it's kind of an exciting time talking about musculoskeletal issues and muscle and CF. Well, it's an exciting time altogether. I've been doing CF care for almost 30 years, and wow, we've come a long way. I can remember when Francis Collins sang at Nashville, "Dare to Dream." Anybody hear him see? That was, and wow, like where we've come since then. I mean, all the things that he sang about in that song, "Dare to Dream," have almost come to fruition. So if you have no idea what I'm talking about, go Google on YouTube, Francis Collins' "Dare to Dream," and it's a cool little tune. So I'm at the University of Alabama at Birmingham, and I'm the adult CF physical therapist there, and also teaching the DPT program at UAB. And so when we do CF, I actually play that song for my students, and they all start singing along, and get out their cigarette lighters or their cell phones and sing along. But anyway, so my topic today is really kind of about aging and the impact of aging. What ETIs and the other modulators may be doing for skeletal muscle. I have nothing unfortunately to disclose. Wish I did. So our objectives are really kind of focused on skeletal muscle. My research interests are in kind of evaluation and intervention of really skeletal muscle, interventions for skeletal muscle in people with chronic heart and lung conditions. So mostly right now I'm doing research in heart failure and cystic fibrosis. But really the common theme between heart disease and lung disease and physical therapy is muscle. It's really the muscle that is kind of the problem here. When our patients go to cardiac rehab, when they go to pulmonary rehab, it's really skeletal muscle rehab. We're training the skeletal muscle to be more efficient. Maybe we're improving lung function a little bit. Maybe we're improving cardiac function a little bit, but we're improving skeletal muscle and vasculature in the skeletal muscle quite a bit. So here's just a great picture that I remember seeing years ago at a presentation. And this is a young, healthy person and an older adult with sarcopenia. And so if you look at their circumference of their leg, it's about the same. But wow, on the inside, it's much, much different. Much different. So just kind of looking at somebody doesn't kind of give you the whole picture. There's a lot of qualitatively different things going on in the muscle, as well as quantitatively, if you could kind of measure, if you were able to measure this. And here is, what is similar. So this is an aging between young and old muscle. And then this is quadriceps cross-sectional area in controls versus somebody with CF. So right off the bat, having cystic fibrosis is almost like a kind of a premature disease of aging. So their skeletal muscles are already smaller than their peers right off the bat. And then if we add on kind of aging on top of that, we see that they have even more potential for problems. And luckily, when I started off doing CF care 30 years ago, we didn't see many patients into their 30s and 40s, and now we've got patients into their 50s and 60s, and maybe even 70s, and certainly, yeah, if you've got a kid born today with CF, they're probably more likely to die of colon cancer or a heart attack or a stroke than they are of cystic fibrosis. So it's really a fascinating time. But with this aging, we need to think about if they start off with less muscle mass in childhood, then what are they going to be like as they get older? If we know that there's age-related changes in skeletal muscle with aging. And so that's what we kind of call sarcopenia, is that age-related decline. And then, with these CFTR modulators, are they able to help out muscle? Is CFTR kind of a major factor in muscle and muscle development? So to start with, let's look at some of the age-related changes in skeletal muscle in normal. So there's the reduced size and number of muscle fibers with aging, primarily due to deinnervation, which is one of the reasons why we can rehabilitate them, is that we kind of activate those motor neurons. We can kind of reinnervate and kind of grow. So once all is not lost. We can rehabilitate folks that have lost these fibers. And these of the fiber types, there's more type 2 fiber loss than type 1. And so that means as folks age and get weaker, they lose more of their strength, more of their power. So simple things, what's simple for us, getting up and down out of a chair, climbing stairs, carrying groceries, getting groceries out of the car and into the house, get more difficult, those things that require more of those type 2 fibers. And, here, we can see how much muscle is lost. So in youth, about 50% of our body mass is muscle, but only about 25% as we get older. And I showed you kind of earlier on that, those muscles get kind of infiltrated with fat and connective tissue, and they also get stiffer with age as well. So the muscles that are left are stiffer. And so here's kind of what we expect over time. Again, this is kind of typical aging, is declining strength. So 2 to 4% a year after age 50. And that doesn't seem like a lot, but if we use 2 to 4%, and you live to be 80, and, between 50 and 80, that's a significant loss. And the strength declines faster than the size does. So somebody might look like they haven't lost a lot, but their strength is losing. They're losing their strength. And so we see this when we see patients, or not even patients, when we see older adults, they move slower. They require more effort to do the same thing. So what might take us 10% of our max to get done, they might be working at 75, 80% of their max. For instance, to climb a flight of stairs. That impaired kind of strength and power increases the risk for falls, decreases their balance. So what about cystic fibrosis? So again, what we were previously talking about was just kind of normal aging in skeletal muscle. When CF, to start off with, they typically have a 10 to 15% lower lean body mass than controls. And this is due for quite a few reasons: malnutrition, pancreatic insufficiency kind of being the big one, but also systemic inflammation takes its toll. Every time they get a lung infection, they have these systemic cytokines that are floating around and damaging muscle. Because of their lung issues, because of hospitalizations, they might be less physically active. So they get deconditioning due to physical activity. And then some of those, especially with acute infections, they're often treated with corticosteroids, and corticosteroids are catabolic. And so just taking corticosteroids kind of breaks down muscle. And so we've seen that, people with cystic fibrosis have lower strength. If we measure their quadricep strength, if we measure hand grip strength, it's significantly lower, between 20 and 30% lower in people with cystic fibrosis. They also have a lower power production. And depending on who, some of the research is a little bit conflicting, but it appears that there's no intrinsic deficit in the muscle, that the muscle itself is functioning appropriately. Each little muscle fiber is doing what it's supposed to do. But it's just the quantity. They have fewer muscle fibers. And that's what's causing the strength and power decrement, not kind of an intrinsic issue with the skeletal muscle. Ironically, and I've written a couple grants and never got funded for this, but I've always wanted to do a muscle biopsy in somebody with cystic fibrosis. As far as I know, there's never been a muscle biopsy taken of a human with cystic fibrosis to actually find out what's going on in the muscle. How much CFTR is present there? What is the fiber type? How qualitatively is it different than the normal muscle? Maybe one day before I retire, somebody will decide to fund that. So what about muscle mass and performance? And especially in this new era of these highly effective modulator therapies. So Trikafta increases lean body mass, increases fat mass as well, increases BMI, increases bone mineral density. But in this study by GERD in 2022, it did not impact peak VO2. So although a lot of these factors were improved, including FEV1, there was no improvement in peak VO2. So the medication looks promising, improved lung function, but in terms of like the gold standard for aerobic exercise capacity, did not improve peak VO2. Body composition in this study from 2024, obviously an increase in adipose tissue, very little increase in muscle tissue. So the weight that they're gaining, and for those of you in the clinic, you probably see this, right? I mean, waist circumference is going up, BMI is going up, but leg circumference isn't getting bigger. Biceps aren't getting bigger. It's mostly kind of adipose tissue around the waist that is going up with ETI. So we're not putting on muscle. We're primarily putting on fat. And then in this more recent study, looking at muscle function and body composition of folks on ETI therapy, there was no change in hand grip strength or quadriceps, maximal volition contraction, no improvement in 1 minute sit to stand or squat jump, and surprisingly, no change in fat mass, fat-free mass, or bone mineral density. So that's a little bit surprising. On muscle strength, there is a little bit of a improvement in this study from 2024 by Ann Sophie that did look at the 1 minute sit to stand test, and they increased from 50 to 58 repetitions after beginning ETI therapy, but they did not have any improvement in quadriceps force or 6 minute walk distance. So muscle strength did not improve. Endurance, as measured by the 6 minute walk test, didn't improve. But I would say this is probably more of a test of muscle power. Did improve in this case. And for those of you that, anybody do the 1 minute sit to stand tests? I mean, 50 is a pretty good baseline, right? I mean, that's a pretty good baseline. And so for these folks went up 8. That's a pretty robust. I'd challenge most of you here, don't try now, to do 58 in a minute. That's a pretty quick rate. So what we found in a sub-study that we did, it was the PROMISE sub-study. There was kind of a longitudinal study of folks after beginning ETI therapy. We were looking at both, so we were testing folks before they started ETI and after ETI. And we were looking at the modified shuttle test for endurance and looking at hand grip strength for strength. And we thought this was such a cool study. It was so excited about it. And it started in 2019. We got IRB approval, I think October 2019. And we're maybe September, August 2019, and started testing some of our subjects. We were doing, again, shuttle tests, shuttle walk test. Some of them were actually running. We did hand grip strength. And then folks started rolling on to, in late 2019, Trikafta got approved, and our patients started rolling on to Trikafta. And then early 2020, well, the pandemic started, and we stopped all human in-person research. And so we couldn't collect a lot of data, follow-up data. We did get some hand grip data, and hand grip strength did not improve in our subset of this of the PROMISE study. So again, starting ETI did not change hand grip strength. Again, kind of giving a little bit more kind of credence to the fact that maybe CFTR isn't playing a specific role in skeletal muscle itself, because hand grip strength, that's about all it's testing is hand grip strength. There's not a lot of cardiac or pulmonary kind of involvement in the hand grip test. On the other hand, this was a recent study that looked at maximal inspiratory and expiratory pressure. So looking at kind of how forcefully somebody can breathe in and how forcefully they can blow out. And this did increase with ETI therapy. So before therapy and after therapy, ETI therapy, they did improve strength here, especially in the maximal expiratory strength. So they're basically their core muscles, their kind of abdominals, their intercostals. They were able to push out more air, generate more force post ETI therapy. So what about exercise? Exercise is still medicine. So obviously the ETIs improves the lungs a lot. But one of the things that I've found in my practice is that patients that I couldn't get to exercise for years, all of a sudden now they're interested. It's like, wow, I'm breathing easier. I know I told you I didn't want to exercise last time I saw you, but I'm interested now. What should I do? So now that a lot of their lungs are being fixed, now a lot of folks are interested in exercising. And so now we can begin to exercise and start to train the muscle, train the heart, and integrate these other components of this, what we call the oxygen transport chain. And exercise has its benefits in more than one place. It's not just skeletal muscle. It's not just the heart. It's not just the lungs. And as folks are aging, especially given the diets that oftentimes they were recommended to eat. I was in a previous session earlier, and one of the people living with CF that was talking about was the diet that they were told to eat years ago. The high fat, the high sugar. Get as many calories in as you can. Well, yeah, those are hard habits to break. And, it's not the same diet that you and I would eat, because we're concerned about getting diabetes and heart disease. Well, now our patients with cystic fibrosis that are living longer, their lung disease is becoming resolved. We're preventing the decline in loss of FEV1. So they probably need to be thinking about preventing diabetes, heart disease. And so exercise, it's good for all of these things. So it's good for your blood pressure. We've had a number of folks now in our clinic that are having more hypertension issues. So we can improve lipid profile with aerobic exercise. We can improve oxidative capacity, strength, improve immune system function, which is obviously an issue for our patients. So exercise is medicine for more than just the lungs, more than just the muscle, more than just the heart. But it's kind of the magic pill that's good for everybody. So just in conclusion, muscle quantity and the quality deteriorate with age. I think cystic fibrosis could be kind of a model of a kind of a premature aging because they start off with less muscle mass. Now they're living longer with cystic fibrosis, thanks to all the developments made with the CFTR modulators that are fixing their pancreatic function, fixing lung function. And although there may not be specific effects to skeletal muscle, I think because they've resolved a lot of their breathing issues, a lot of their lung issues, now we're able to address the muscle. Maybe we can kind of build more muscle mass, build more bone density, so that these folks can live longer, healthier lives, able to be more physically active and doing the things that they want to do. And just like aerobic exercise has always been kind of the key, or used to be kind of the focus of our exercise interventions, because we wanted them to do aerobic exercise because it was helpful with airway clearance. But I think they should all be doing kind of resistance training now too. In fact, I think we should all be doing resistance training. I lived in a neighborhood of a lot of older adults. And especially the men, as I've watched the men get older, I've seen them get kind of smaller and smaller and frailer. And, now it looks like they've all been taking that drug. What do they call it? No acetol. And so, it's a little,
It took me a second.
second.
like-
And so, whether you're, young with CF, middle-aged with CF, or if you're an older adult without CF, I think resistance training is important to maintain that muscle mass, as you, get into, older, age. And so here, just kind of some of my kind of references related to sarcopenia and CF muscle, and the effects of CFTR on tissues as well. So, with that, happy to take any questions.
Please come up to the mic if you have questions. There's also the app that you can do it on too. So while we're waiting for people, John, is there an age that you're starting to see this regression with as far as, with CF, are they teenagers or is it 20s or 30s or where are we starting to first see that big change in muscle mass?
I don't know that we see a great change in muscle mass so much as we do in kind of older adults because we haven't been looking at it, I think, long enough in folks with CF. So most of the changes I was referring to were kind of in kind of older adults without CF. But I don't think we've looked at kind of longitudinally in people with CF yet.
Okay. Come on, you guys.
But certainly I think I would expect that people with CF would lose muscle mass at least the same rate, if not faster, than people without CF.
So John, in clinic, besides the 1 minute sit to stand test, I know that you utilize, do you do any like handheld dynamometry for like quad strength or anything like in clinic when you see individuals or?
I do have a hand grip dynamometer, and I don't use it consistently. We do have a hand grip dynamometer that we're starting to use more frequently. And we also have a device to measure the MIP and the MEP, the maximal inspiratory and expiratory pressure. But I usually use just those on kind of a more kind of case-by-case basis, not anything systematic.
And do you do any training, like with the research there, with inspiration or expiration strengthening at all? Is there anything that you end up doing around those types of things to help with the lungs? But also we know that that works on the core strength there too.
Right. So, kind of on a case-by-case basis. So, if folks have some kind of inspiratory muscle weakness, usually the device I usually use is the Power Breathe device, kind of a handheld. It's kind of a muscle inspiratory muscle trainer, and maybe a half a dozen folks I've used that with. But those are with folks that kind of had inspiratory muscle weakness. Other than that, the one thing I've just recently kind of started doing this, and there's no kind of evidence for it, but it can't hurt. That's the good thing about a lot of our PT interventions, right? They can't hurt. I mean, maybe they make them better, but they certainly don't cause any side effects. And so while we're at it, let's see, you've been sitting for 30 minutes. Everybody stand up. And so I do this with patients sometimes, and just kind of push in kind of on your lateral to your kind of rectus abdominis. And just kind of push in there, if you're like me, it's a little softer than it should be. But now stand on one leg and kind of feel what happens. And so you're kind of activating your core, everything kind of tightens up. You have to kind of use your core muscles to kind of hold yourself up. And so, one of the things I've recently started doing is just, having patients do that. I was like, hey, when you're, and oftentimes they have some balance issues as well. So, if they've been on kind of, aminoglycosides and have, has some odor toxicity, maybe their balance isn't all that great. And so it's just having, hey, when you're brushing your teeth, do it on one foot. When you're combing your hair, doesn't take very long for me, but, brush your teeth while you're standing on one leg. If you're doing things during the day, washing dishes, do it on one leg. And that's, you're working on your balance, you're working on your hip strength, your ankle strength, coordination, your core strength. So it's just kind of a simple thing that I've started, trying to get patients to add into their ADLs.
Yeah, on that note too, I would think because some of the drugs that we're using can cause vestibular issues, and as you get older, you have those issues anyways, I would think that that might be a important area for us to look at in the future too.
Yeah, and your balance can't be too good, right? I mean, if you go to the gym, you can get a little bit too buffed, right? It's not my problem, but I mean, you can get too big, right? I mean, you got to walk funny because your legs are too big, or you got to hold your arms out. But I mean, nobody's balance is better than it needs to be. You know, I mean, you can't have. There's no side effects to having too good a balance.
So, any other questions right now? And if not, you can go on the app and still ask questions, and we can steer them back to John to see if he can answer them later on the app. So I think with the app, it's something that's, I think when you start off in the beginning, it ends up being new and people don't know how to do it. And by the end, you start throwing a zillion questions out there. So just know it's out there to come back and ask any of us questions. So, we'll continue to move forward there. Andrew is going to be our next speaker, talking about the shoulder. Andrew, do you want to click?
And again, I have nothing to disclose. So like Julie mentioned, my name's Andrew. I am a physical therapist at Nebraska Medicine. I'm a part of the adult CF center there, and I've been with them for the last about 2.5 years. I'm part of the CF grant, PT grant, and hope to continue after the grant. And then when I'm not at the CF center, I am working outpatient as an outpatient physical therapist at Nebraska Medicine. So today, I want to talk about shoulder impairments in persons with CF. My objectives are to describe common presentations of the shoulder impairments in individuals with CF, identify contributing factors causing shoulder impairments, and then apply evidence-based assessment and interventions to optimize just the shoulder health and overall function. So why am I, up here talking about the shoulder? So we know that musculoskeletal symptoms are common in individuals with CF, especially as life expectancy continues to improve thanks to the modulators. There was a study done in 2017, a cohort study involving 2 large CF centers in the UK, and approximately 77% of the 489 participants reported musculoskeletal pain in either the back or joints over the last year. In that same study, about 42% of people reported shoulder pain over the past year. So then I, at clinic, I usually ask about musculoskeletal complaints, whether pain complaints or just, just having a nice conversation with my patients. And I started noticing, as part of their pain complaints, shoulder being part of that. So in our clinic over just the last year, I just looked back at chart history, and I noticed about 8% of the people I had screened during the last year at the time of the screening reported shoulder pain. So, and then just shoulder impairments, we know they can affect airway clearance, positioning. It can also affect breathing efficiency. So maybe, if they're having shoulder pain, they may not want to be doing the best treatments or different posture positionings that may be causing pain when they're doing the airway clearance. Exercise, activity participation. So they may be less inclined to be as active, maybe because of the pain, or some fear avoidance behaviors that occur because of the pain. And then activities of daily living, like, reaching, lifting, dressing, things that we think of when we are using our shoulder. So just a quick overview of the shoulder anatomy. I won't spend too much time on this, but when we think of the shoulder, we typically think of the glenohumeral joint, which is a ball and socket joint, and it's that humeral head and the glenoid fossa of the scapula. And I like to think of it as more of like a golf ball on a tee. So it's actually the fossa is pretty shallow. So what's nice about that, though, is we have a lot of mobility that occurs at the shoulder because it's that analogy of the golf ball on the tee. But what we need to also realize there needs to be then stability occurring at the shoulder as well. And then we're going to talk about the acromioclavicular joint, which is the clavicle and the acromion process of the scapula. And so that's that articulation. It's kind of like the roof of your shoulder, if you think of. And underneath that roof, we have some structures, as you can see up here. We have some, like a bursa sac, some tendons. So that's just something to be aware of, and I'll be talking about that in a little bit. And then we have our sternoclavicular joint, which is your sternum and your clavicle that comes together. And then also your scapular thoracic articulation, which is your shoulder blade that rests on your rib cage. And though it's not a true joint is what we think of as joint, it's that articulation, but it's really crucial in proper shoulder mechanics. And again, I'll touch base on that in a little bit. And then, like I mentioned earlier, because it's more of that ball and socket is like sitting in a shallow socket, that golf ball. We need this static stability. So we have shoulder ligaments and labrum that help provide that stability. Along with some of the bony anatomy, we have main muscles of the shoulder. So the ones I really want to touch base on are rotator cuff muscles. So there are 4 specific rotator cuff muscles that help provide more of that dynamic stability. So we talked about the ligaments and the labrum providing more of that static stability. The muscles here help provide more of that dynamic stability of the humeral head in that socket. And it helps with raising the arm and rotating the arm, these rotator cuff muscles. And then we have important scapular stabilizers that provides, again, scapular stabilization, positioning, and movement of the shoulder blade on that thorax. So they all work together to help with proper shoulder function. So speaking of shoulder function, shoulder mechanics, I'm going to touch base on that today. So the shoulder is a pretty complex joint, so I'm going to try to simplify it as much as I can. It needs to maintain, again, a balance of both mobility and stability for proper function. So a key movement pattern that we should be aware of is the scapulohumeral rhythm. And what that is, so let's say if you're looking at the model here, or I should say a little video. So as you are to raise your arm out to the side, that first 0 to 30 degrees is mostly that ball and socket joint. So mostly that's just moving right here. So if I'm moving out to the side like this, it's mostly that ball and socket joint that's moving. From the next 30 to 90 degrees, it's a 2-to-1 ratio of the ball and socket moving, but then also your shoulder blade rotating, that upward rotation through there. And that's the second component. So it's a 2-to-1 ratio there. And then from 90 to 180 is a 1-to-1 ratio of your glenohumeral joint and then your scapular thoracic. So again, all this works together in order to have proper shoulder mechanics. And if it doesn't work properly, then we can get shoulder issues, impingement, which I'll touch base on a little bit. So again, while the humeral head is rolling, it's kind of hard to see here, but while the humeral head is rolling up, it needs to glide down. So that's the way it's not pinching up on that roof of the acromion there. And then those rotator cuff muscles help to center it. And then, like I mentioned before, those scapular muscles help to position it and tilt it posteriorly and rotate it as it's moving up. So I really wanted to touch base on shoulder impingement. So it's because one of the most common shoulder problems, and it occurs when there's structures that are being pinched or irritated just underneath that subacromial space there. Typically like your rotator cuff tendons, bursa, things like that. It typically presents as achy pain in the front of the shoulder or the side of the shoulder, pain with overhead activities like reaching, lifting, dressing, even laying on that affected side. Pain felt at that you have a painful arc, so it's felt that around that 60 to 120 degree of motion. So again, a lot of people with that, again, reaching tasks. So contributing factors as to why people can develop shoulder impingement. forward shoulder posture, increased thoracic kyphosis, weakness of the main stabilizers of the shoulder, like your rotator cuff, your scapular stabilizers, and some muscle length and tension imbalances. So let's say if you have tightness in your pec, it can pull those shoulder blades forward. So those all together can affect the shoulder mechanics. And often we see in clinic, individuals with CF often present with some of these contributing factors. So just for an example, I want everyone to stand up for me. All right, so I want us to try our best to have a really forward flexed posture, increasing that spinal curve. And then I want you to try to raise your arms up as high as you can while being that forward flexed. And then come back down and then do the same thing out to the side. So as you can notice, your range of motion is a little bit limited and you may have some pain or something. So now I want you to bring the shoulder blades down and back, proper posture if you can. And then I want you to raise your arms up and come back down and then out to the side. So as you can see, just even posture positioning can affect the way the shoulder mechanics are throughout the motion there. Thanks for participating. And again, just to touch base, so often in clinic, we'll see thoracic kyphosis in individuals who have CF, again, that rounded upper back, often due to that chronic hyperinflation, barreled chest, and more of that expanded rib cage, which changes that scapular position. We also have, again, that rounded, protracted shoulders. Like I mentioned before, tight. You can have some pec tightness, and your scapular stabilizers can be weak. Along with the scapular stabilizers, like scapular winging from serratus, anterior weakness. And then this forward head posture, often linked to overuse of our accessory muscles that are breathing, accessory muscles for breathing. So what do I do in clinic? So when I see individuals, I try to see them at least once a year or more, if possible. And during my screening, I will ask about musculoskeletal complaints, pain complaints, and in specific, if they're complaining of, let's say, shoulder pain, I will ask, the classic, when did it start? Was there a mechanism? Was there an injury? What makes it better? What makes it worse? So I try to do a quick subjective screen because, as some of you may know, you may have limited time with your patient. So just try to make the best of it and say if I need to come back to it later, I can see you next time too. But so I try to ask about pain complaints. I look at their posture. Like I said before, looking if they have rounded shoulders, what's their scapular positioning, are they kyphotic, just kind of looking at overall their alignment there. And then I will just do functional reaching tasks. So I'll have them reach overhead, reach out to the side, behind their back, behind their head, just getting a general functional movement screen of their shoulder. If I have time, then you can even do some muscle length testing, like the pec minor testing, as well as some strength testing. So I'll look at their rotator cuff strength. I'll look at their scapular stabilizers, see what their strength is there. Again, based on what you have available in clinic, if time constraints and everything like that. So, and then if you feel comfortable, I will sometimes also do special tests to rule in or rule out shoulder impingement. And here are a few special tests that you can utilize to help rule that in or out. So big picture, just a quick screen can flag who may need more in-depth follow-up with either physical therapy and or orthopedics. So just doing that quick screen in clinic can be very beneficial for patients. So interventions. So based on what I see in clinic, I can provide some interventions as needed. So if I see range of motion deficits when they are reaching, whether it's due to pain or just stiffness, I can provide them with range of motion exercises. So sometimes I'll do active assisted, whether it's wall slides. I have them go up to a wall, do some wall slides. They can use a stick and help with active assisted range of motion of their shoulder. Talk about pulleys if they have access, or I can provide that with them in an outpatient setting. As well as passive range of motion. Typically, I won't be doing this in clinic, but if they were to get referred to me in an outpatient setting, I could do passive range of motion on their shoulder. Also, some manual therapy techniques to the shoulder. So we can do some glenohumeral glides, typically inferior gliding to help with giving them more joint space when they're raising their arm forward or out to the side. Can also give out and perform some scapular mobilization techniques to help facilitate proper mechanics of that shoulder blade. If there are some restrictions in there, can help facilitate that as well. And then also, as we normally see that increased thoracic kyphosis or forward flex posture, I will do some thoracic mobilization to get them to more extension. And I can do that in clinic, or I can also prescribe exercises to help facilitate that as well. Again, provide stretches for muscles that are typically weak. So again, normally we'll see tight pecs, lats, upper traps, scalenes. So for pec stretching, I typically will have patients go like in a corner or a doorway, and they could stretch out their pecs that way. Sometimes on a foam roll as well. And I know that Julie's going to touch base on some foam roll interventions later. So yeah, just again, stretching what's tight. And then for strengthening, I will strengthen obviously if I notice anything that's weak during clinic. So typically like rotator cuff, mid traps, things like that. I'm lucky enough that I have bands in clinic. So while in clinic, I usually will provide bands to my patients. So again, for more like rotator cuff or more trap, mid trap, low trap strengthening, I usually give out very, very basic ones to start off with. So a lot of times I'll kind of just demonstrate a few of them. So if I can. So I usually have them hold on to the band, and they'll work on scapular squeezing back through here. And that way they really bring that scapular into retraction, and more working on scapular setting. I try to have them really bring their shoulder blades back. And so they're involving their rotator cuff and their scapular muscles. But there are many, many different interventions. I won't be here just to explain all the different interventions. And if you want to have a discussion afterwards, or you feel free to let me know. And then with like scapulohumeral rhythm, I try to promote that as well. So just one basic one that I usually do is I'll give them a wall slide, and then I can also have them work on setting their scapula. Sorry, can you guys hear me okay right now? Okay. I wish I had a mic. Anyway, so I work on scapular setting, and then with upward elevation here. So I bring the shoulder blades back, and then I can work on bringing the arms up like that. If that's too advanced, then I can always have them start with just bringing their shoulder blades back and just again working on that scapular setting, kind of like what we did earlier on, just practicing bringing the shoulder blades back. And then, like I mentioned before, so I'll provide them hopefully with a home exercise program in clinic. I'll say, hey, here's a simple home exercise program that you can do. If you're having issues after this, I'm happy to see you in an outpatient setting. So if you're still lingering, we can get a referral to see me in an outpatient setting, and I can work on them outside of CF clinic, or I can help provide them with other resources if they're not local, give them resources for other PT clinics, or they may need to talk to their PCP about possible referral for ortho, things like that. So again, just basic things of quick screen, help them with some simple interventions that, like John said, with PT, luckily, it's pretty safe. Of course, you still want to rule in and rule out certain things, like if they had a fall, we want to be mindful of that. But just providing them with little things here and there. So some special considerations. So though joint pain in persons with CF is typically mechanical in nature, it is reported that inflammatory arthritis is present in 5 to 10% of people with CF. So it's important to be mindful of, especially, we're doing like PT interventions. They may also need referral out to like rheumatology as well to help with management of joint conditions. And another thing that I wanted to touch base on was adhesive capsulitis. So for those of you who are not familiar with adhesive capsulitis, it is a shoulder condition where the capsule becomes inflamed and the tissue becomes stiff, and causing, again, pain, stiffness, and range of motion deficits for the individual. And we know that persons who are diabetic are more prone to developing this condition. So it's important for us to have that consideration in mind, especially if we're working with individuals who have CF-related diabetes. So just being mindful of that. And typically we can see that in clinic pretty quickly. Significant range of motion deficits usually occurs, especially in the later stages. So just being able to point them in the right directions, whether it's PT-related or other disciplines as needed. So just wanted to throw that out there. And like I mentioned before, so there's other management. So referring out to PT, orthopedics, rheumatology, imaging, if we know that there's a mechanism possibly, pharmacologic management, injections, if, for example, the adhesive capsulitis or severe tendinitis, and then hopefully not, but there's a possibility of even requiring surgery, like rotator cuff repairs or that subacromial decompression where they come in, they can clean up that area, give you more space for that, right underneath the roof of the shoulder there. So in conclusion, shoulder impairments like impingement is a common musculoskeletal complaint in persons with CF. There are multiple contributing factors, like I mentioned, altered posture, muscle weakness, tight muscles, and an impaired shoulder mechanics. The CF team, specifically, PT can screen for musculoskeletal problems like the shoulder impingement and facilitate, hopefully, at least early intervention as appropriate. Treatment often includes manual therapy techniques, strength training, stretching, and a huge one that we can easily do is postural education. I think that just goes a long way. So if you have a really short amount of time with these patients, just even talking about postural, just educating them on posture, whether when they're doing their treatments or just activities of daily living, if they have a desk job or, just having those conversations is really, really important to do with these patients. So big picture, people with CF should be aware that they can seek advice and direction from their CF team. I think that's very important for possible treatment options when experiencing musculoskeletal issues like the shoulder. So, these are my references. Any questions?
Great job, Andrew. It was good to have that review. I know many of us involved in CFPT don't do as much as the musculoskeletal stuff as you do being an outpatient PT. Next, I want to say, I really hope you can continue beyond the grant as well, because your patients are super lucky to have you, as are the rest of us in the CF community. So thank you and good luck. An article came out recently for the general population in the last year or so about musculoskeletal syndrome of menopause, with adhesive capsulitis being one of the things mentioned. And I'm curious if you've seen perimenopause, menopause changes that may be affecting the shoulder or other joints of the body.
That's funny you say that. Yeah. So I had, within the last couple of years, I had 2 individuals who were perimenopause. around perimenopause who had developed frozen shoulder, whether it was like a year prior to when I saw them or during the clinic visit. And so, again, a lot of education. I had ended up seeing one of them in the outpatient setting, and we worked on a lot of interventions in the outpatient setting to help with management. So yes, to answer your question, I have seen at least 2 individuals in clinic. Yeah, so.
We have a question on the app, and it's, it just disappeared. Okay, I'll have to go back to that one. I have one. So, do you see any correlation between your shoulder pain and back pain? Because I do know sometimes we substitute what we can't do with our shoulder with our back.
Mm-hmm. Like particularly like low back or just back?
Yeah, low back. So,
Low back
or do
pain.
you see somebody that might have low back pain and you find out that it might be correlated to the shoulders?
Yeah, I mean, I feel like there are times where patients can present with multiple pain complaints. I don't really know if I've seen, because they're describing that they have a pain in their shoulder, that again, they're going to also have low back. So I can't really say that in clinic I see that often, but there will be patients who have, multiple pain complaints, and shoulder and back could be part of it, but not just those 2. Yeah.
Okay.
So, one of the things you didn't hit on was thoracic outlet syndrome. Is that a common, have you seen that much in CF as well?
I haven't seen it as much in my clinic. I don't know. Have you seen?
I've had a couple,
Okay.
not many.
Yeah.
Thoracic outlet syndrome.
Want to describe what it is?
Yeah. So thoracic outlet syndrome is when you get some compression onto your either vasculature or nerves that exit out of the brachial plexus area. And so it can be due to like tightness, usually tightness in like your scalenes or your pec, as well as if you have like an elevated first rib can also impinge on that area. So individuals will have like nerve symptoms. They can have burning. They can have coldness sensation in their arm because of their vascular and or nerve structures being compressed. And so there are special tests that you can utilize to help rule out that. But I haven't really seen it too much in my clinic, but something to be aware of for sure. Definitely. Yeah.
Yeah, just so that people are aware of it, if you're one of the PTs working in an outpatient clinic, we had a kind of a rare case of somebody that had a DVT from their PICC line that was causing thoracic outlet syndrome. So it was and I'd never heard of it before. It was a venous thoracic outlet syndrome. So I'd always heard of thoracic outlet syndrome as being arterial or neurologic. Well, there also is something called venous thoracic outlet syndrome. And so if you've got some unusual symptoms, then think about that as well, especially if they have had a chronic line placed.
Okay, we have a question. Why do people with CFRD have greater risks of adhesive capsulitis?
Well, there's a lot of research on persons with who are diabetic and in the general public are more susceptible for adhesive capsulitis, and I think it's more in the cellular component of I don't know the exact physiology on it, to be frank, but I know that persons who are diabetic are more susceptible to developing adhesive capsulitis. So that's why that correlation of if you have CF related diabetes, then you may be more prone to developing it as well.
Okay. Do you reassess the patient for improvement on their next visit then?
Yes, I do. So sometimes I will do range of motion tests in clinic. I have a goniometer, and then I can also reassess range of motion and or pain complaints that way in clinic. And if I see them in an outpatient setting, of course, I'm going to evaluate them and do subsequent treatments, and then do a progress note and see what their improvements are. So, yeah.
Great job, Andrew. I was
Thanks.
just going to give a little bit on that adhesive
thanks.
capsulitis
Yeah.
too. A lot of the things with diabetes, this is kind of important for your whole talk about musculoskeletal and pain. It's inflammation. So there are higher risks of inflammation. And I think there is something also that changes the collagen levels. So like you said, I know about general diabetes and it's like 2 to 5% more common, I think, for patients who are diabetic, or even higher.
I think it's a little bit higher. Yeah.
I think it's higher actually now that I'm saying it out loud, but inflammation is a big thing. And I think people who are diabetic or have CFRD, we should be concerned about that because it's going to cause inflammation in the potentially whole musculoskeletal system. So just adding that 2 cents.
Thank you so much.
So thinking about some of the alternative techniques that you can use if you're kind of running dry with some of the traditional techniques. I don't know what's allowed in Nebraska, but your thoughts on dry needling, if you try dry needling, especially with these patients that have like a chronic cough, are having these muscle imbalances and getting kind of significant sort of tightness and really like trigger pointy in certain areas. I don't know if you've tried it at all or have thoughts on it.
Yeah, so I personally am not dry needle certified, but we can do dry needling in Nebraska. I did have a patient in the outpatient setting who I felt like would be appropriate for dry needling because she had trigger points, upper trap trigger points. So I had one of my colleagues do dry needling on her and it was beneficial for her. But it's important to realize too, like along with the dry needling, obviously all the other important postural strength training and everything like that. So for her, doing a little bit of dual was perfect. And I did for that case and it did help. So good thing to bring up. Yeah.
Any other questions?
Anything else?
Thank you, Andrew.
Thanks for your time, guys.
I just want to put a plug in and say thanks to the CF Foundation because Andrew and Jamie, our next speaker, are both products of the CF mentoring program. And so it's exciting to see these folks that were mentees of some of us in the room are now up here presenting at NACFC. So it's, yeah. So for those of you that are helping organize and run that program, here's proof that it works.
Thanks, John.
Hi, I'm Julie Christensen. I'm from Children's Hospital in Minnesota. I've been there for just about 33 years, and I've probably been working as a physical therapist assistant for the last 25 plus years there too. So I'm really excited to be talking with you guys on something that I have a passion for, which is breathing in the rib cage. At my hospital, they call me the breathing lady. And so they're always calling me in on different patients. I feel like breathing is something we all do. And I also feel like there is some really simple things we can do to help benefit our patients. I have nothing to disclose. We all know the anatomy, but when I look at the rib cage, I kind of get excited. Look at all of that stability there. We've got the sternum, we've got the ribs, we've got the spine. But when we have stability, we also want to have mobility. And so how are we going to keep some of that mobility going here in the rib cage for our breathing, for our inhales, our exhales? So I think it's important to kind of keep in mind that we have a lot of stability there, but we're going to want to make sure we have the mobility there. One of our biggest breathing muscles is also our biggest posture muscle, the diaphragm. And so with the diaphragm, it has such a big purpose to be able to move not only in the rib cage area, but it is dividing up our two cavities there. So with that, there's a ton of ability for that diaphragm to help with the rib cage moving, unless there's issues with it. If you're familiar with Mary Mastery, have any of you guys gone to any of Mary Mastery's classes? Amazing person. I would highly suggest her if you are anyway fascinated with the breathing. For PTs, RTs, speech therapists, occupational therapists, there's a lot of people that get a lot of benefit from her. But with this pop can theory that she has is that I look at it as our trunk is like a pop can. And so if we think about this, we have our vocal folds that are at the top, and we have our pelvic floor, which we'll hear more about later, at the bottom. And then in between, we have that diaphragm, and we need to have the perfect pressures in order to have the perfect breathing system. So if we end up having more pressure in our thoracic cavity from coughing, pushing down, it can affect where the diaphragm is going, what that abdominal cavity is doing. And so then that changes that pop can not to be as stable. So if you take that pop can and you open a can of pop, it collapses. If you put it in the freezer, it bulges out. But if you have that can of pop and it's closed, you can't crush it because it's so strong. And so that's what we're going to want for this area up in here, is to have a very strong rib cage, mobility, ways of keeping those pressures in the right dynamic there. The breathing muscles, if we look at it, this is where we get our mobility. So we have our intercostals. I think sometimes those muscles are forgotten about. They're teeny, they're little, they're between the ribs. But if you even go in on yourself and feel, they're there. You can feel them. You know, we've got the diaphragm doing a lot of that up and down movement, changing of pressures. There's even more muscles, and the muscles of the shoulders go into the breathing. You know, we have all of the muscles in our neck, and it appears that a lot of our patients will be accessory breathers and using so much of these muscles in their neck, and that's not a very efficient way to breathe. We have our abdominal muscles, which work on that. So if we have tight muscles, we're going to have even less mobility in our rib cage. So I work in peds. But I do a lot with kids. I will use these things on infants. We've just had a couple new diagnoses, infants that come through our NICU, and I spend time with parents on breathing and movement. So it's not just for old people or middle people. It can be for the infants too. But there's a very big difference between adult rib cages and infant rib cages. And I believe that normal development promotes a normal rib cage. So if we have kids that are having problems with breathing, or I look back at the kids that I saw that used to have the typical CF posture and being very thin back years ago, they didn't have that normal movement, that normal mobility. So now as they're in adulthood, these things can show up from their younger childhood, that these things that have been, maybe the drugs we know now don't take away the stuff that's already been there. So to just know that it's different. And even like with development, like tummy time pulls that rib cage down. You know, adults, our rib cage goes at an angle. With babies, they start off this way. Babies should be abdominal breathers. Then they should carry that on. But a lot of times we don't see those types of things. So one of the first things that as far as doing an actual measurement or whatever, doing a chest expansion measurement tends to be a really good way to see where you have your movement and where you don't. So I'll quickly show you a little bit on Andrew here. Our issues are the microphone. Most of us probably have a standard measuring tape, okay? I'm going to have you face me. Sometimes I do it from the back because it's kind of weird to be in people's faces. But I do 3 areas, upper, middle, and lower. So let me come under your arms. The upper is usually right under the axillaris. And what I'm going to do is I'm going to pull the tape out, and I'm just going to talk to Andrew and let him breathe. And what I'm going to do is when he inhales, my tape should separate. And when he exhales, it should come back together. So I can sit here and watch the millimeters and go, oh, he's moving approximately 4 millimeters. Then I'm going to want him to take a really deep breath in and let it go. And I'm going to have him do 3 of these. Usually I do about 3 breaths to be able to get kind of an average. And with this, you should see obviously an increase. So I would do it at the uppers. I would do it at the middle, which is right below the bra line. And then the lower rib cage is in between the xiphoid process and the navel. And so by doing these measurements, you would be able to see where there is maybe more deficit. So there are some normative values. The ones for the kids aren't standardized. Mary Massery developed these, but I have been using these. But with these measurements, you can kind of see what's normal. The other thing that I like to do is just compare the patient from when I do the beginning of my session to the end, because you'll find where you touch, you change. So the second you start touching, you're going to start changing these numbers. So where do they function in the beginning? Where do they function before you've even touched them? Where are they functioning probably in their everyday life? I primarily see kids in the hospital, but now we're not seeing as many of them. So this would be a very simple test that you guys could do actually in the clinic that doesn't take much time at all, just to see if there's any issues in certain areas. So if for some reason you had a lot of movement in the upper chest, which should be a little less than the lower chest, that might be a red flag. I know one time I had a patient that when we were doing some research, all of a sudden her rib cage movement increased significantly. She ended up in the hospital. She was sucking air. So that's the reason why she was starting to have more movement. It wasn't due to a positive thing. It was due because she was getting sick and she was trying to get more air into her lungs. So this is my first one. There's a lot of go-tos you can go to. The arms overhead, which Andrew did for shoulders, but you can also do that to see where is the rib cage moving. R is the scapula winging, things that would show you more issues with the rib cage. The side bending, a lot of times you can bend over, and this is usually one, none of these are standardized, but if you did this and were able to compare before and after treatment to where you're leaning over and you measure how close the hand is to the floor. Doing prone in the V-up or Superman types of things, measuring the shoulders from the mat. And this is the one area that I think is overlooked a lot, the quadratus lumborum. And for those of you that aren't PTs, you might be going, really, what is that muscle? It's the muscle that attaches your bottom of your ribs to your pelvis. So if that muscle's tight, that is holding your rib cage down at the bottom. And there's techniques you can do to help with this. When I'm dealing with smaller kids, it might just be some simple massage. Usually with older kids and adults, you really have to get in there and you have to use some deep massage to kind of break up that tissue there. And I've had it where if you loosen one side, the patient almost looks like they're just going to walk in a circle because one side is loose and the other side's so tight. So it is something that you can really make a dent on some of that ribcage stuff just by focusing on that. And then the intercostals, are they evenly spaced? Can you feel the tightness in those areas? So this is where I call the magic happens. So going into some hands-on types of things. So going back to the intercostals, if you right now go to yourself and just sit up straight, but try to get your fingers between the ribs and give a little push, usually you'll find you're sensitive. Now I'm kind of weird when I'm standing waiting for the elevator, I'll stand there and I'll play with my rib cage. So because I just think it's so fascinating and it feels so good to go in there and do a massage. So I'm going to jump ahead to the rib cage springing. So rib cage springing is, Andrew, you want to stand up here? He didn't know he was going to be my guinea pig. So what I do is I put my hands on the rib cage and I just kind of pretend it's a little trampoline and I bounce in and out to feel where the tightness is. So if you're doing this is a therapeutic technique, but you're also assessing what's going on in the rib cage too. I know, sorry. So if you're doing the rib cage springing, then you can go back and go, oh, I need to do some intercostal massage. Also, intercostal massage, if you have any patients that have had any kind of chest tubes, surgery, anytime the ribs have had something between them, you're going to get scar tissue. And that scar tissue can go back. Lateral thoracotomy is correlated with scoliosis. And it makes sense because that adheres down on one side by the spine with the ribs, right? And so you get that pulling. But even simple chest tubes, a G-tube, all of these little different things can change the body. And so that's where you might get tightness on one side of the rib cage versus the other. If you have significant tightness, you can go in and actually do some rib cage mobilizations. So what I want you to do right now is take a second and stand up, and you can do it to yourself or you can do it to a partner. And I want you to just start. I always do 3 areas. I do the lower. So squeeze in there, feel how things are moving. Then let's go to the middle and kind of squeeze and then go underneath those armpits and squeeze. So you should feel more mobility down in the lower area. We got floating ribs, right? And then as you go up, you do have less movement, but you should still have movement. And I'm guessing there's probably many of you that were going, I'm not moving at all. So all of us need to sometimes work on these areas. So the diaphragmatic scoop is a way of helping facilitate the diaphragm. And the mechanism of it is just being able to touch. So this is where I start getting into where you touch, you change, okay? So if I take my hand and I go up here hard, I'm going to breathe up here. So, you know, it's very important for us to watch where our hands are. Even, you know, with the RTs and the doctors and stuff, you know, it's like, you know, a stethoscope can pull them up into one area versus another area and trying to figure out where things are going. So with the diaphragmatic scoop, we'll see if this video works. This is my daughter when she was littler. All it is it going to work? There it goes. All it is taking the side of my hand in, I guess it's not working, and pushing it into the belly. So somewhere you don't have to be, in fact, it's better not to be right underneath the diaphragm. It's better to be down a little lower. Let's see if it's working. There we go. So, and as you're going in, she's taking a breath. And when she takes that breath, my hand comes back out. And then I assist that exhale. And then my hand gets pushed back out with her inhale. And so the brain so wants to take the easy way to breathe. And with that easy way, it's going to start picking up on this. So even if you do it with yourself right now and do a little karate chop straight into your belly, and think about taking a breath all the way down to your belly button, you should feel your visceral tissue push your hand down. So it's not physically the diaphragm jumping all the way down there to push it down, but it is stimulating that diaphragm. And I know when I have patients that have had repair of their diaphragmatic hernias, you can feel the difference between the left and the right side. But by facilitating both sides in the middle, a lot of times you will get the opposite side to be able to move a little bit better. So just by touching, you can change it. Now, when I'm teaching my patients to do this to themselves, a lot of times trying to think about, okay, I'm scooping and stuff is too much. A lot of times just getting their hand down there and say, you know, when you exhale, just give yourself a little pressure in. My neonates, when they have been accessory breathing because they're premature lungs, you will have a parent hold them in a way where they got maybe just a nice neutral neck, put your hand on their belly and follow that breathing in and out. And those babies pick up on it right away. They want to belly breathe. And the parents can see the relaxation in their face. So I think it's a really important thing to just know that something so simple as touch and teaching your patients to touch is just a really big deal. Okay, so breathing facilitation is diaphragmatic scoop and the breathing facilitation are probably my two big things that I use for therapy. And this one, I have my patient laying on a pro roller. I like the pro roller because you can go and you can stretch and you can open up the chest. I'll get the patient on that. I'll start talking to them. I'll put my hands on their rib cage and I'll start following their breathing in and out, or I'll start doing some rib cage springing. This is also a very more intimate position. So this might be where I ask about other things like stress urinary incontinence and things like that Jamie will talk on. So it's one of those things that just being there, but when you start talking and you're feeling things first, then I move down to the idea of, hey, why don't you find my hands? My hands are down here, trying to get them to be able to push my hands out. And it's really interesting because most people think breathing is just automatic. But you can really actually go in and control where you're breathing. I can take kids and say, breathe with your left side, breathe with your right side. Let's come back to the middle. And they think it's so fascinating. And then they have control over it. Even my young adults that we end up seeing, I use this a ton for our cardiac heart surgeries too. So I think with the breathing facilitation, it just gives you that ability to help them change where their movement is. And then what I do is I take the patient then and have them start feeling it. I put my hands on top. I have them breathe in and out. in and out, and they start to learn that they can control it. Sometimes I'll take the breathing facilitation and add their hands down a little lower, add that diaphragmatic scoop in. But I really feel like with patients, giving them that power to go, you know what? I can change my breathing. And I will tell you, just about every single patient that I've ever worked on in our gym with this, they go, I didn't know breathing could be that easy, because they get in this pattern of accessory breathing or chest breathing. And we should really be able to breathe forward, backwards, out to the sides. And then our accessory muscles should be used when we're running up a flight of stairs and we really need it and we have to take that breath at the end. Some of our patients, especially when they're in the hospital or they're sick, or even if they have issues with pain can pull you up into this area. We had issues with masks. You put a mask on, you start accessory breathing, your mouth breathing, so there's a lot of things that can change our breathing. So now we're all going to try it. So once again, you can do this to yourself or you can find a partner. PTs are used to touching other people. I talk to the RTs, they're not used to touching. So what I want you to do, let's have you stand up. Okay. And you're going to put your hands on that lower rib cage. So you're going to definitely feel the bottom of the rib cage, not so much down by the waist. And I want you to just stand there and just kind of try to take a normal breath and see if those hands are moving at all. My guess is some of you, they may not be moving. Some of you, it may be moving a lot. Now I want you to just kind of push in a little bit and take a breath in. And feel your hands go out. And then when you exhale, push in and just follow that breathing through about 3 or 4 breaths. Now just have your hands gently rest in that area and take one more breath. If you feel your hands moving, and if they weren't moving before, you're starting to facilitate that area. Let's go up to the next area. Do the same type of thing. Take a breath in and exhale. And every time you exhale, just give that gentle, I'm going to squeeze a little bit of that air out. Now, one of the areas that you may want to be a little bit more cautious of doing this is if you had somebody with osteoporosis. But I do this with my sternal with my cardiac heart surgeries. And this does not bother that type of thing because you shouldn't be pushing that hard. Sometimes you have a heavier patient, so you really have to dig in there and do it. Okay, let's go up one more level right underneath that armpit. Before you start feeling your breathing, kind of go in again and feel how tight that area is. That's a harder area. So really think about trying to take that breath into your hands right here. And the goal is not to do this. The goal is just to feel that breath going in and out. So now by doing this, we all should feel a little bit more relaxed. We should be able to get that breath. And now you can take your hands down, and I want you just to imagine taking that breath in from your belly button. And a good breath in should start in the belly and work its way up. And when we exhale, it goes down. So to see if you can imagine, and if you need your hands on your rib cage, you can go ahead and do it. But take a belly breath up to the sternum and then back down through the chest. Ready? Blow it out. So just by touching, all you have to do is go in and work with your patients and get them familiar with doing some things like this, and then they become more aware. Now, a home program for somebody that we're working, Andrew, for a patient is, I'm going to have you face me. We're going to do some rib cage range of motion, the same type of thing. So I'll start them at the top here. What I want you to do is take this hand and grab onto this, and this hand and grab onto that one. And so he's going to be doing that same kind of squeezing, but he's going to do it to himself. So he's going to take a breath in and his hands should come this way. And then when he exhales, he's going to give himself a squeeze. And we can actually take this to a level where we're actually doing rib cage range of motion. So it's just not following it. It's going, you're squeezing to get that rib cage range of motion. I find that my patients are willing to do that. You can then move it down a little lower and go with that. And so by doing this, going and doing all your therapy and then going back and measuring, you probably will see a difference in the increase in range of motion. Thank you, Andrew. Yeah. Some other things that you can do to help with this is I love taping the diaphragm A little piece on the front, a little piece on the back. It can help facilitate the diaphragm to breathe a little bit better. I also like taping the intercostals, especially if you have one side that's tighter. If you've had somebody with chest tubes, to be able to run that tape right over the scar tissue there. The one picture I don't have is upper traps. We could all probably use a little upper trap taping. This works out really well for accessory breathing. So if you go and you throw some tape on, I go with tape. It's either going to work or it's not going to work. So why not try it? And then the last thing is going back to that pop can where we have pressures. So if we add an abdominal binder or an ACE wrap around the middle, it's not there just to hold the patient up. What you're doing then is you're giving that support to the abdominal cavity, which causes the diaphragm to be in a more stable area. So I find the patients are able to actually take a better diaphragmatic breath because that diaphragm is going to be more inflated where it's supposed to be. And then when they exhale, it's going to go down. So I use abdominal binders on all ages, from infants all up to my teenagers and my young adults that I see. So with this, my conclusion for you guys is where you touch, you change. So start touching, no matter who you are, to start feeling your patients and seeing where that is, because looking sometimes just doesn't do enough, especially when they have clothes on. You can't see some of those subtle things. These are my references. And questions, anybody?
Hi, how are you? Hi. Great presentation. One of my questions about the pop can is how do you see the rib mobility change with someone with a weak pelvic floor versus someone with like a chronic trach or has been vented for a long time?
So when you have a trach, that's opening up the top of the pop can, right? And so a lot of times trachs, they can cause you to more collapse. It's kind of like if you're sitting on the edge of your chair, and you can try this too, but you sit on the edge of your chair and I want you to just stand up once and just feel what your body does. Okay? So you feel it, the muscles are working. Okay, now sit down. Now this next time you stand up, exhale slowly while you do it. So not a big, huge, that's going to help you, but just a slow exhale. So usually when you stand up and exhale, you'll feel like you don't have quite as much strength. And that's what a trach will do, is because that air isn't there. A lot of times our speech therapist and myself will work with the passing mirror valve because that puts the pressure back into the pop can. Now, Jamie's going to be talking a little bit about pelvic floor, but that pelvic floor works with the diaphragm. They have to work together. So if you end up having dysfunction in your pelvic floor, the diaphragm may not be working and vice versa. So it's a matter of looking at that whole unit here. And that's kind of why we liked what we picked for this, is because we're kind of covering this whole area and how they work together. Any other questions?
Oh, sorry. I thought you were sitting down, Andrew. I didn't know you were going to ask a question.
No, good.
I just wanted you to maybe explain too, because we did all these demonstrations standing up, but how I feel like I use this more when they're in side lying or supine or stabilize the rib cage. I don't know if you do standing
I use
or
it
supine.
I did standing up because we're here, but I kind of do it in whatever, it depends on the patient and positioning. So when I had the patient on the Pro Roller or the foam roller there, I a lot of times will be doing that breathing facilitation, that diaphragmatic scoop there while I'm trying to open up and just increase the rib cage. There's times where, I'm working with the patient and on their breathing and, how does it relate to a vest treatment? Usually they're sitting down with their vest treatment. Is there anything they can do with their posture? Even feeling that diaphragmatic breathing while they're doing their vest treatment. Side lying is a anti-gravity position for breathing. So when you're side lying, the anterior and the posterior part of the rib cage can move better. And it's interesting because we always think, I'm laying on my back, this is the easiest breathing position. But it's truly not the easiest because gravity is pushing down. So when you're thinking about these things, you're thinking about different directions. I will have a mother that's holding her baby. She's got her hand on the posterior part of the rib cage. Let's feel that breathing there. I will do things in prone where I'm trying to get them to push up against me so that they can get that posterior part of their rib cage there. So I think it all depends on what your goal is, but positioning can really change the muscles that you're working with. Thank you, Holly. That's a good thing I didn't touch on.
So are you using like active cycles of breathing or huff coughing associated with during like the rib mobs and things like that, or?
I tend to not do those things. The huff coughing is probably the one thing that I will use with my patients. But using the huff cough with exercising, if it's cardiovascular or whatever, can be considered some form of airway clearance. So I probably do more of that. But what I do notice is that when you start doing this, especially if patients are in the hospital, you'll start noticing an increase in coughing because now they're taking that air that maybe they were more upper chest breathing or the middle chest breathing and getting it all the way down. And that's what I tell them. You're getting that air down to the bottom. It's like a balloon, you want to be able to blow up all the balloons in your lungs. So if you're not getting the bottom ones, then you're going to have problems. So you start getting the air down there, and then I feel like it helps with airway clearance. I will always do my cardiovascular exercise after my rib cage. I usually do rib cage, and then I might do some core strengthening, and then I'll move into some cardiovascular. Okay, thank you guys. Next we have Jamie here, but before she starts, I just want to announce that today at 6 p.m., so after the little happy hour event there is, over in the Hyatt in room 303, in the Bogacelli room is going to be the USA PT meeting. So if you're a physical therapist here in the United States, come on over and join that meeting. Welcome, Jamie.
Alrighty. Can everyone see and hear me okay?
Maybe.
I think it's an important question. I'm slightly shorter. Yeah. Thanks for sticking around through this last presentation today. My name is Jamie Anderson. I am a PT at Boston Children's Hospital. I've been working in our CF outpatient clinic and working with CF patients inpatient for just over 6 years now. And one of my colleagues, Eleni Moulis, is my counterpart for the adult CF clinic. She unfortunately is not able to be here today, so I'll be covering this presentation, but I will have both my contact information and her contact information at the end of this presentation. So if anyone has questions, I will obviously be here to answer them today. And if there's anything that you have specifically for Eleni or want to continue the conversation, we'll definitely be able to do that. All right, this is the disclaimer slide, and there's no relationships to disclose. My objectives are to review pelvic floor anatomy and function, discuss the relationship between CF and pelvic floor dysfunction, and examine the role of PT in identifying and treating pelvic floor dysfunction. So I know this is certainly a review that everybody here knows, but just for a foundation for the rest of what I'm going to talk about today, CF is a genetic disorder that affects the respiratory, digestive, and reproductive systems. We know that it's going to be characterized by the production of thick, sticky mucus that's difficult to move from the airways, and this can lead to bacterial growth and respiratory infections. Some symptoms can include a persistent cough that's productive of sputum, frequent lung infections, wheezing, shortness of breath, and poor growth or poor weight gain despite having a good appetite. Infants might be screened on newborn screening, and then a diagnosis of CF would be confirmed with a sweat test or genetic testing. And management has definitely evolved over the past couple of years, but this will typically involve some components of airway clearance, inhaled medications, pancreatic enzyme supplementations, and CFTR modulators. So I'm going to be talking about pelvic floor anatomy next. And before I jump into the content here, I just wanted to acknowledge that both males and females can have pelvic floor dysfunction, although what I'm going to be primarily talking about is pelvic floor dysfunction in female populations. And so the anatomy here is going to be that of someone that is assigned female at birth. But that's not to take away from the fact that our patients with CF who are males might also experience pelvic floor dysfunction. There's just only so much time today. And so our pelvic floor is hammock shaped and separates the pelvic cavity from the perineum. There's going to be 3 layers of pelvic floor muscles. So this picture here separates the muscles into the superficial and deep. We can see my mouse is working over here. So we can see that first, the superficial transverse perineal muscle here. We have the bulbocavernosus or the bulbospongiosus. And that is just going to be depicted differently depending on how old your text is. So the updated muscle is the bulbospongiosus. We have the ischiocavernosus here and the external anal sphincter over here. That second layer of muscles is going to be the deep transverse perineal over here. And then the sphincter urethrovaginalis and compressor urethra are not in this picture, but they're part of the external urethral sphincter complex. And the external urethral sphincter is pictured here. And then we have our levator ani muscle group here, and our coccygeus down here. I'm not going to talk about each muscle in detail related to the function, but I am going to talk about more globally the function of the pelvic floor. So the pelvic floor has many different functions. The pelvic floor is going to support the abdominal and pelvic organs by acting as a dynamic muscular hammock, counteracting the downward force of the intra-abdominal pressure that's generated by breathing and voluntary movements. So our levator ani muscle is in a constant state of low-level contractions and almost acts like a continuous lift that's supporting organs from below. So during activities that increase any intra-abdominal pressure, like coughing, laughing, lifting, the pelvic floor muscles are going to contract strongly and reflexively to resist that downward force, acting as a stable platform to prevent the organs from falling or prolapsing. And this coordinated effort of the pelvic floor muscles, the fascia, and other core muscles provide a stable base for the entire abdominal pelvic cavity. The muscle's ability to tighten and relax allows for the control of urine and feces, which helps to maintain continence. And additionally, the pelvic floor muscles are going to help to support a fetus during pregnancy and then relax and stretch to allow the infant to pass through the birth canal during vaginal childbirth. A strong and flexible pelvic floor helps to prepare the body for the increased pressure of the fetus and helps the muscles to lengthen during labor, which aids in easier recovery postpartum by promoting better muscle control and function. The pelvic floor is also very important for sexual health. So this does tie in very nicely to what Julie was talking about earlier. So as we know from her presentation, the diaphragm is going to be really important with breathing. We know that this is the primary muscle of inspiration and has a very unique relationship with the pelvic floor. So the diaphragm is comprised of 2 domes and a common tendon. And during inspiration, we're going to see that that diaphragm is going to move down, causing the pelvic floor to lower. And when you exhale, the diaphragm is going to move up, causing the pelvic floor to rise. So this is commonly referred to as the piston effect. And this synchronous movement helps to control intra-abdominal pressure, supports the organs within the pelvic bowl. This connection between the diaphragm and the pelvic floor is fundamental to pelvic health, and it impacts functions like continence and core stability. So pelvic floor dysfunction can present in a number of different ways, depending on the root cause and individual considerations. But just as with any other muscle group, we can see that our pelvic floor might be tight, it might be weak, and it can also be tight and weak. In the CF population, we frequently may see people with pelvic floor weakness related to chronic coughing, as opposed to someone with a tight pelvic floor which might result in symptoms such as chronic pain, difficulty with bowel or bladder evacuation, painful intercourse, or sexual dysfunction. Versus with pelvic floor weakness, we may see urinary or fecal incontinence, pelvic organ prolapse, or a sensation of heaviness that indicates the loss of muscle support. And knowing that a lot of our patients may be chronically clenching due to fear of leakage, we might see that they're developing some of these more hypertonic symptoms in addition to that of a weak pelvic floor. It's also a consideration with our CF population that with the chronicity of coughing, someone could develop these hypertonic symptoms. Overall, pelvic floor dysfunction will lead to the inability to relax and coordinate the pelvic floor musculature, and this can occur after certain life events such as childbirth, surgery, or just as we age. Childbirth, particularly vaginal delivery, may impact the pelvic floor through mechanical damage to muscles and nerves, overstretching and tearing connective tissues, and cause hormonal changes as well that can weaken the supporting structures. These physical changes can lead to various pelvic floor dysfunctions, such as pelvic organ prolapse and potentially urine or fecal incontinence. We know, just as with any other muscle group, that our pelvic floor muscles are going to experience age-related degenerative and fibrotic changes that lead to reduced strength and stiffness. Particularly for females, the decline in estrogen during menopause can also affect pelvic floor tissues, which makes these tissues weaker and more prone to dysfunction. All right, so this is a bit of a busy slide, but I'm really excited about it. Ultimately, the goal is just to show how common pelvic floor dysfunction really is. It's very common. A study entitled Pelvic Floor Dysfunction, Prevalence and Associated Factors, which was published in 2023, found that over 50% of women in this study had some form of urinary incontinence. And this was just in the general public. This was not specific to anyone with CF or lung disease. And this study was looking at women 18 years and older. We know that with chronic pulmonary conditions like CF, we're going to see associated pelvic floor dysfunction due to that increased intra-abdominal pressure from chronic coughing. This can also be true of younger people, including children. An article, The Prevalence of Pelvic Incontinence in Patients with CF, published in 2017, found that 38% of patients in this study, aged 6 to 21 years old, had pelvic incontinence. And this study came out before Trikafta. So I was really interested to see how pelvic floor dysfunction might have changed over the past couple of years as we're seeing more people that are eligible for and on these highly effective modulators. And I think that there's probably still a great deal of research that needs to be done, and there are some really great articles that are out there. Another study that was published in 2023, the prevalence and severity of functional urinary and anorectal disorders and their impacts on quality of life in CF, found that 34% of participants reported stress urinary incontinence. So this study looked at, again, people 18 and over, but this study included both males and females, and both did report having that urinary incontinence, but 64% of that 34 were females. And then prevalence, impact, and specialized treatment of urinary incontinence in women with chronic lung disease, published in 2019, looked at women with CF, COPD, and women with no chronic lung disease. It was found that most women with and without lung disease reported incontinence. Specifically, people with CF reported, 71% of people reported having pelvic floor dysfunction and incontinence, 70% of those with COPD, and 55% of women without chronic lung disease had incontinence. So really just to highlight, we know how common this is amongst the whole population. And once we add on that layer of CF, chronic coughing, and other life events that people are going to go through, this is a very common a very common thing that we'll see in our patient population and something that's really important to be screening for. So symptoms of pelvic floor dysfunction are going to vary, but they could include urinary or fecal incontinence, constipation, or incomplete bowel evacuation, or pain and pressure in the pelvic region. So as physical therapists or healthcare providers, we have a very important role in asking questions to identify if patients are experiencing pelvic floor dysfunction. We know that some people may disclose this information regardless of whether we ask, but oftentimes people feel uncomfortable disclosing this information. And we know that there's so many things we can do to help to optimize pelvic floor function. But if we're not identifying the need, we're not able to capitalize on this. So acknowledging that this is common, normalizing that this is something that happens and validating that experience, and then making sure that we're asking the question, this is very common for people with CF. Is this something you're experiencing? If nothing else, is opening a dialogue so that we're able to provide the interventions that we feel comfortable with or refer out if we are not able to support them fully in our clinic setting. So the role of PT in CF care is evolving and certainly cannot fit on just one slide. But we know that we may be providing recommendations for airway clearance. We might be providing recommendations and assessment measures for exercise, targeted strength training and resistance training to help enhance our muscle strength and endurance, and also identifying pelvic floor dysfunction. All things and more that we're able to support in our clinic roles. So I'm sure people are very familiar with airway clearance and the role in CF. We might be seeing people use a variety of different techniques, whether it's manual chest PT, the vest, PEP devices, exercise, but really all of these options are going to include some degree of deep breathing and huff coughing so that we're able to effectively mobilize secretions. Again, some great crossover between Julie's presentation and mine. I'm also going to be bringing in Mary Mastery's soda can analogy. I won't repeat everything that she said, and I'll be taking a slightly different view, given that we're focusing on the pelvic floor here. But if the diaphragm, pelvic floor muscles, or core muscles are not functioning properly, this is going to ultimately impact the ability to absorb shock and transfer those forces in an appropriate manner. So as we know, Dr. Mary Mastery describes the core muscles as being like a soda can. So if you squeeze, shake, or push the can when it's unopened and full, meaning that there's enough intra-abdominal pressure, it won't lose its shape or leak. But if the can is open and you squeeze, shake, or push it over, it'll lose its shape or leak. If your pelvic floor or core muscles are not functioning properly, it's hard to maintain enough intra-abdominal pressure to prevent leaking. And we know that this can happen during many activities of daily life. So jumping, laughing, sneezing, running, all things where we might see this. A chronic cough is going to put constant increased downward pressure on the pelvic floor, and this can lead to pelvic floor dysfunction, particularly stress urinary incontinence. Coughing is going to increase that intra-abdominal pressure, and if the pelvic floor muscles are weak or uncoordinated, they may not be able to contract effectively to support the bladder and urethra, causing leakage or a feeling of heaviness in the pelvic region. So people with CF who are pancreatic insufficient may have malabsorption of nutrients, causing decreased muscle mass. And we may see decreased absorption of vitamin D, which can play an important role in muscle strength. People who are experiencing increased episodes of sickness or infections may have decreased energy to participate in activities that properly fuel the body and allow for building strength. And these are things that traditionally may put someone with CF at an increased risk for pelvic floor dysfunction. And now with more advanced care available, we're seeing people live longer and longer, which is great. And we know that advanced age is a risk factor for pelvic floor dysfunction. And additionally, as newer modulators are coming out, we're seeing more women with CF have babies. And again, great news. And we know every mom or mom-to-be could probably benefit from pelvic floor PT. So taking these considerations that we've always known with CF and also looking at that from the lens of what's new in CF care and new risk factors that we might be seeing in our CF population. So pelvic floor dysfunction can be diagnosed in a number of different ways, including a physical examination by a certified healthcare provider. So this could be an OT, PT, or gynecologist, and this could include an assessment of pelvic floor muscles. Providers may perform an ultrasound, MRI, or CT scan to help obtain more information about potential causes or dysfunction. Providers might also obtain specialized tests, such as a urodynamic test, which is going to evaluate the bladder and urethra function, showing basically how well your bladder is emptying. So during a pressure flow study, which is another part of urodynamic testing, the flow rate is measured simultaneously with the pressure inside the bladder. All these tests are going to be directed by someone's past medical history and their subjective symptoms to help guide what needs to be done. We know that so many people are impacted by pelvic floor dysfunction, and we know that this is going to impact activities of daily life. So we're seeing this on a day-to-day basis, and that it's not necessarily talked about at the frequency it should be, considering how many people are impacted by this, which can really lead to, in addition, the negative impacts of the symptoms themselves, feelings of isolation and not knowing where to turn to, and just feeling like, will I get relief from some of these symptoms? So pelvic floor dysfunction can definitely have a negative impact on quality of life, especially if we're not identifying it. As PTs, we're able to provide specialized interventions to address symptom management and restore function. So this could include the use of biofeedback, where sensors are used to provide feedback and increased awareness of pelvic floor muscles. Sensors are placed in different locations to monitor muscle activity, with the primary types being internal probes or external electrodes. The specific placement is going to depend on the patient's condition and the therapist's goals. Usually there are 2 active electrodes and a reference electrode. A potential setup for biofeedback for someone being seen at Boston Children's for pelvic floor dysfunction could include electrodes on the levator ani muscle, the TA, and then a reference on the ASIS. This is not to be said that everyone who's being treated will have that exact setup, but just to give you a sense of where those electrodes might be being placed. This immediate feedback can help patients accurately identify and learn to control the correct muscles, which is especially useful for those who have trouble isolating the pelvic floor. In addition, PTs may be instructing patients with pelvic floor muscle training. With any muscle, we want to lengthen before strengthening to ensure proper alignment, to optimize the ability for those muscles to respond to strengthening. So for lengthening, this could include diaphragmatic breathing, happy baby, child's pose, or depending on the age of the patient, if they're an adult, potentially internal trigger point releases of those tight muscles. We might be instructing patients in Kegels, but pelvic floor PT is very much more than just that alone. Going back to the definition of a Kegel, it's going to be that coordinated contraction and relaxation of the pelvic floor muscles with the goal to strengthen or work on the endurance of pelvic floor muscles. So we might be bringing patients through a full range of motion from contraction to relaxation, working on endurance holds for those slow twitch muscle fibers or quick flicks for those fast twitch muscle fibers. And working on both of these is really important to maintain continence throughout the day and also during those higher intensity moments of a cough, a sneeze, a jump, things like that. And then we want to make sure that we're also ensuring strengthening of the supporting muscles. So we know that our glutes, hamstrings, and deep core muscles are all going to work in conjunction with the pelvic floor to stabilize the trunk and hips. Education is also really important. So we can be providing education on lifestyle modifications, including a balanced diet with high fiber, limiting the intake of bladder irritants such as caffeine, alcohol, citrus fruits, or carbonated beverages, making sure that people are properly hydrating, obtaining proper sleep and managing stress, and also doing what we can to limit constipation. Constipation can really exacerbate any pre-existing pelvic floor dysfunction because of that pressure that's going to be put on our pelvic floor. So promoting bowel regularity with use of physical activity, using a squatty potty, and putting people in the best position possible to be successful, to minimize and maybe even prevent some of these symptoms. In conclusion, I just want to highlight the relationship between chronic respiratory symptoms and the potential impact on pelvic health, the role of PT in identifying and treating pelvic floor dysfunction, and just ultimately knowing that despite how negatively people with pelvic floor dysfunction might feel, that we're really seeing very positive results come from engagement with PT. So we might see improved quality of life, breathing control, and better pelvic muscle control. And then these are the references and Eleni and my contact information here. Thank you.
Do we have any questions? We have a very important one here. So is it a pop can or a soda can?
Oh, I feel strongly that it's a soda can.
And I say pop.
Oh, man.
Exactly.
Yeah, raise your hand for soda.
Midwest. Pop.
Yeah.
It's just like gray duck or gray goose, right? For your.
Anything else?
Yeah, I know we didn't touch on the male that much, but what would be warning signs for a male to have some kind of pelvic floor dysfunction so that people could be aware of that?
Yeah, I think even thinking about some of the subjective information, if we're seeing increased frequency of urination, sometimes that can be a sign that we'd want to dig a little bit deeper, or any pain or discomfort in that region as well could be an indication that we need to ask some more questions and get some more answers.
Do they tend to have stress urinary incontinence, or would you say it's more fecal incontinence?
In my research, usually more fecal incontinence, but they can also experience stress urinary incontinence as well. But just because of anatomical differences, females are going to be at a higher risk for that stress urinary incontinence than males.
Thank you, Jamie. Get to go to our happy hour now, right?